to moderate this session. It is going to be demonstration of posterior nasal nerve neurectomy by Dr. Ahilasamy.
Hello, good afternoon.
Hypertrophy on right side. There is a DNS towards the left side. Nasal mucosa was pale and bluish. S-shaped DNS with left bony septal spur. Bilateral inferior turbinate hypertrophy. Left middle turbinate conchobulosa.
Correct.
Now we have live relay from OR.
Are they audible? Hello?
Yes, sir. Please go on.
Hello?
Yeah, we can hear you, sir. Please go ahead.
Ahila, can you hear us?
Yes, yes. Your volume is little less.
We can hear you.
Okay. So, good morning to everybody. Before I start, I must thank Dr. V Anand, a great friend of mine, for the invitation to operate and chair a session in this Congress. And more thanks to both Anand sir and
voice is becoming faint.
Hello?
The voice is not clear.
To the mask. No. So, am I clear right now?
Yeah, now it's good.
Yeah. And more thanks to Dr. Anand sir and Aishwarya for the wonderful arrangements in ensuring a smooth passage of the conference and a nice hospitality and welcoming me. Thank you to all the MCV staffs also in the OT everywhere and everything. So before I start, I will show the CT scan film. Dr. Aishwarya had told everything about the history. One thing I want to small correct that it is not watery discharge, it is mucor discharge. There are some youngsters sitting in the hall. For them, watery discharge means it is CSF leak. It is an mucor discharge in allergic rhinitis. But patients will come and say, "Mukla tanniya kottadu," but it is mucor. Okay. So I am not going to bore you with the CT like anatomy radiology class, but generally I will tell the positive things. The septum is quietly fairly all right. There is a small conchobulosa on the left side and a slight septal deviation to the left side. I think I can go ahead with the septal, and there is slight mucosal thickening and left maxillary sinusitis is there. The plan is to do bilateral postnasal neurectomy and address the maxillary sinus. If I can't get the way on the left side, I may do a septal correction. And depends on the size, I may crush the conchobulosa also. Okay? Any doubts, you please keep on asking me. I am doing the case under local anesthesia with IV fentanyl and dexmedetomidine. Okay?
The anesthetist is with you, Ahila.
Always I will have anesthetist with me. Box.
Can we have a look at him to make sure he is there? Yes, Dr. Satish. We can see you.
You can tell what mic is here. It's okay. Conchal Crushing. So now we can. You have seen the CT scan. Is it all right?
Yeah, we have finished the CT. Yes.
Okay. Now I will start. Sister, I have to stand here.
Satish, you want to say anything about the extra drugs you have used?
Yes, sir. We are using fentanyl 2 mics per kg and dexmedetomidine 100 mics in 100 ml NS. Now for loading dose, we are using maintenance of 2 kg for this patient.
Do you think it is safe to give these drugs without you?
No, sir.
Thank you. Thank you.
Thank you.
Yeah, that's the point I want to stress.
Hello, always have the anesthetist with you. In all my local anesthesia presentations, I will put a picture. Am my volume all right, or I need to raise the volume?
Perfect.
Okay, I always put a picture of that Mahabharata picture, the chariot in which the Arjuna is going and Karna is driving the chariot. So in surgery also the same thing. The surgeon is the Arjuna and the Krishna is the anesthetist who is standing here.
But Krishna
No.
tells Arjuna what to do, no?
Yes.
Here we can't do that.
Okay. Zero-degree scope. Now I think we will go for the endo picture. You can show the.
Can you show the endoscope which you are using? Have they given you the Olympus?
They are given the Olympus.
Okay, so this is something which I just got it from the stall. Till now we were using only stores. So the Olympus company has also these endoscopes. So
Okay.
let's see how the performance is. You can also tell us, Ahila.
Okay. Stores. I want. Hello. You are getting endo picture or external picture?
Can you give the endo picture, please? Yeah, we got it.
Before the external picture, the table is in the 30-degree head and elevated. Okay? Can you appreciate? The head is reverse Trendelenburg position.
Yes, we can see.
Reverse Trendelenburg position. And the monitor is in front of me. Can you switch on the light source?
Endo light source on.
Endoscope light source on.
White balance.
Light. Yes. So first of all thing is you have to, what is the scope, madam? 0 degree. Okay. You have to find focus. Number 1. Number 2, white balance. White balance is all right. Okay. And this external picture, the zoom is very small. So you have to increase the size of the zoom. Now this is the perfect size of the zoom. All these things has been taken care. The nose has been packed. Never pack the nasal cavity outside or without by the assistant nurse, etc. I just packed while I was waiting for the transmission on the table with the endoscope guidance. That too a small pack anteriorly. Now I will keep on packing. Dressing forceps. The pack is of roller gauze soaked in 4% lignocaine. What is this? Cautery. Okay, it's okay. 4% lignocaine and adrenaline in the ratio of 1:1. That is 10 ml of 4% lignocaine and 10 ml of adrenaline. Yes. This simple pack I am taking out. I want the antifog. Usually I use Zavlon in my places as antifog. Here they are using antifog solution self pack. Give me
No,
pack.
Akhila,
Okay.
we use this anti-fog only for taking some pictures or video.
Okay.
Something I want document.
No.
Otherwise, we
That-
always use
bowl.
the nasal mucosa.
Bowl.
And the mucus secretion from the inferior turbinate is our anti-fog.
Okay, but I am used to that.
Yeah, fine.
Yeah, individual preference and everything. In fact, we use Savlon even for stapes surgeries also. But some people say that it is harmful, everything. I think Anthony also use Savlon for stapes. Will be using today afternoon, I think. But I think this OT doesn't have Savlon. I don't know. Okay, it's fine. Anyway, whatever it may be, we'll manage. So keep gently for the beginners and youngsters, gently pack without traumatizing the turbinates and septum. No RBCs should come out. Repeatedly spend 5 to 10 minutes to get a good decongestant effect. You have to see the sphenopalatine foramen area where I will give the blocks. And always never have a camera tilt. So hardly if you see any space, both sides. Okay? Audience? moderators. So you have to decongest well before you start the procedure.
Ahila, we have given, I think, preoperative steroids for 7 days in this case,
Okay.
as is a routine for all the endoscopic or septoplasty procedures.
I also do the same. I do even for tympanoplasties also sometimes to make it, because we do endoscopic, we make it very dry.
And one more preoperative drug we use is Otrivin nasal drops.
Okay.
That is used in the pre-op when patient is given pre-med. And that is done for all ENT cases. Generally, due to the apprehension, the nose gets blocked. So you give Otrivin, that problem is not there.
Give me. So keep on packing till you get a good space. So many people I have seen, they are in a hurry to start the surgery. Never be in a hurry. So far 25 mics given, huh? Fenton? Okay, that's fine. Okay. So now you have got some space, and you can see the better this middle turbinate. Still some more focusing needs. You need to see the vessels. Can I have source scope? Pack. So next again you have taken the pack, repack, still you could see well the sphenopalatine area. You can see there is a trickle of mucus there. I'll suction on.
The concabulosa,
Yes.
you said you would like to crush it. What about resecting the lateral part?
There are many ways to kill a cat. It all depends on you. Sometimes I resect also if it is an infected concabulosa. Here it is not an infected concabulosa.
For those juniors who are starting the FESS for the first, say, 50 cases, opening up this concha makes your endoscopic sinus surgery much easier. So it is like tympanomeatal flap in the ear. You open tympanomeatal flap, middle ear is open. So you take care of this concha. Sometimes the middle turbinate is very anterior, not bulge, but more anterior. There you take a punch and take out the middle turbinate to a level where you can see the bulla ethmodalis.
Okay. I also used to do plasties all these days. Now also selected cases I do the conchal crushing. Otherwise I still do. Put it
It is
there.
the best procedure for juniors to start endoscopic sinus
Small
surgery
elevator.
because you can't do
Small
anything very wrong. Instead of doing uncinectomy, start doing the concha, because here when they come for fellowship, that's the first thing we give them. Either concabulosa reduction with 15 blade and removal, like what Kailash told, lateral part, or give a punch and take out a thin concha also, you punch out and create space. Once OMC space is there, it's easy to do any type of surgery there.
One more pack. So pack nicely into the crevices, that is into the middle meatus, superior meatus, depends on the working area. Remember, I am going to do, I have to decongest well. I am going to do a post-nasal neurectomy, which is a very vascular area where I am working. In GS, sometimes if it is very bloody, you can't able to see the nerve. When I learned the technique from the Japanese, they used to cauterize the whole area with cautery. They don't see the nerve and come out. I myself learned identify the nerve because I was doing under local. I could get a little better feel under local anesthesia. Here, let's try if our field is good, and sometimes nerve may be thin, we may not be able to find out. Let's pray, we see the nerve. It's just something like a trip to Anamalai, where you go for a tiger safari. You may spot tiger, or you may not even spot a cat, and you have to come out. The dialogue was told by Dr. Anthony in Nagpur All India Conference. he and Dr. Suresh Kumar and a co from MMC went for a tiger reserve to see tiger. The whole day they spent. Finally, how many tiger you saw? I asked. They told that they didn't see even a or pooniyam kuda paakalan. That means didn't even see. Okay, let's pray. We'll try to see. This said, I will be doing an MMA. That is mini FESS. I will take out only the lower one third of the uncinate. And there are two ways of doing post-nasal neurectomy. One is to avoid MMA and dissect from the posterior lip of the MMA and do it. The other way is just without doing MMA, you start working from the just anterior to the posterior attachment of the middle turbinate. So right side I will show one technique, left side I will show the other technique. And there are many people who coagulate the whole area like Dr. Sadish Jayan with what is that coabulator and come out without identifying the nerve. But always when you see the nerve, identify and cut it or coagulate, that's always the best thing. Here there is a medialist or double middle turbinate, what we call as medialist uncinate, prominent bulla. I can't see the area at all. So okay, let's pack some more. I can't see the spinopalatin area.
Arya, what solution you gave for the pack?
10 ml of adrenaline with 10 ml of 4% liquid.
Sheila, can you tell us the solution you have used for this pack?
I will tell you are not. Already I told, again I am repeating, that is 4% lignocaine, xylocaine, and adrenaline, pure adrenaline in the ratio of 1:1. That is 10 ml of 4% lignocaine and 10 ml of pure adrenaline. Whether local, all local cases I do the same. GA I may sometimes use pure adrenaline also.
This is like tequila.
Yes. Pure.
Anesthetist, are you noticing any rise in pulse rate, please? Can you tell?
So always when you pack, the pulse doesn't increase, but when you inject, the pulse shoots up. I will show it that also.
So the rule is once the pulse crosses 100 or 110,
Stop injecting. Stop injecting.
Yes.
And once it comes down, again start injecting. This may be boring, these steps are boring for the seniors, but for the beginners it is a must, or anybody it's a must. You have to get a good decongestion. Next one slow, but keep going slowly. So we give a moderate sedation, do not over sedate. I tell my anesthetist, even patient doesn't cooperate, don't give anything extra, they will still more do not cooperate.
Excuse me, sir. Dr. Anand used to tell us to keep a dam for all local cases. Other thing is packing, he usually prefers soft roll packing. I remember.
Some
packing.
I love this because it is very thin, it is prepared by my nurse. I brought it from Chennai all the way. Wherever I travel abroad, I carry this pack. So there are a lot of packs in my bag. I bring it, it's so slender it goes into the crevices.
What Murugesh Pandian is trying to say,
Okay.
when you are putting local into the nose,
Okay.
we don't want local anesthesia for the pharynx. Because then the patient starts, they will.
That's why we are keeping under moderate anesthesia. Whenever I ask the patient wake up, she has to wake up, swallow, she has to swallow.
So another question, what is the indication for neurectomy, sir?
Allergic rhinitis or any rhinorrhea with snow.
Both sides you are doing.
Pardon me?
You will be doing on both sides.
Always it's a surgery has to be done on both sides.
Okay. Thank you, sir.
So he is, in other words, asking, what is the indication for surgery in an allergy which can be very well controlled by medication. When medication fails, this is the stuff we have to do. And in case-
Otherwise also, this patient has a recurrent left maxillary sinusitis. If she comes to you for sinus surgery, you do only MMA and leave it and ask her to take medication regularly. She will ask, again you are asking me to take medicines. So if you do this surgery and if it is successful, then this patient will be very happy. No need to take medicines post-operatively. Am I correct, Anthony sir? Sorry, Anand sir?
Yeah, I'm here.
Yes.
Basically, I try to differentiate between allergy and vasomotor rhinitis.
Okay.
And in patients, you have allergic overlay with vasomotor predominance, or it
Okay.
could be the other way around. So when you give these medicines, if it is vasomotor
scope on that.
predominance, then response will be poor. So in that case, if the patient is young and the joints, ankle joint, knee joint are okay, you give them any type of physical exercise that takes the pulse rate to 110
long
beats a
needle.
minute for about 20 minutes. That's probably one of the best decongestants known to us, but it can't be done by this lady who's 50, 60, who's having some diabetes, knee joint. But in a young patient, a hard physical exercise liberates catecholamines from the central nervous system, which are very potent and much more potent than your amines which we use in the nose. They say about 3,000 times more potent, the centrally released amines. So exercise as a first choice.
What is the drug, sir?
Oh, it's not a drug. It's a chemical that is neurotransmitter that is released when you do hard exercise. And you have to keep your pulse rate about 110 beats a minute for about 20 minutes to that to happen. That is why all these patients who are in students and all, they'll say software engineers, when they are in college, when they were playing basketball and football, nose was all right. Now they are getting issues.
Some more.
So that's a good indication that exercise will stop it. Ladies, you can prescribe jogging, the skipping indoors. People, just walking is not going to help, because you need the pulse rate to go up to above 110 for the central release of amines to happen. But believe me, it's highly potent, much more potent than your pseudoephedrine tablet or your Otrivin drops. But when those don't work, in this case, an old lady who can't be asked to do exercise, I'm sure Ahilasamy's procedure will help her.
So now I am giving the spinopeltrin block at the area where the middle turbinate curves and joins the lateral wall. This is the area above the inferior turbinate. You can appreciate some blanching, but the picture quality is, I am not very happy. You can stop. So, some more. Since it touched the middle turbinate, I am giving an anterior ethmoidal nerve block at the axilla or at the root of the middle turbinate. See, the pulse has jumped to 101 from 70 now because of the infiltration. So far, the pulse was not varying when I was packing. Now, when I was infiltrating, the pulse jumped to 100. You can hear the beep sound.
Yes, we saw the monitor.
This is the anti-ethmoidal nerve block. Since now the pulse is coming down, I am injecting.
So why he's looking at the pulse? There are susceptible individuals with susceptible conductive systems where beyond 140 or 160 is absolutely danger line in pulse rate. 180 is very dangerous in BP, systolic BP. Beyond 160, you can go for atrial flutter if it lasts for few minutes. That's why at 110 itself, we stop injecting the medicine.
So now I will go go to the other side. Now the pulse is around 99, coming down from around 110. These infiltrative areas, little ooze, which will hinder the surgical field or fog the surgical field. So I am keeping the pack for some minute. Okay, sir. Hope I would have got some decongesting effect to do a yes. Yes. Please keep the suction on. Do not switch off. In ENT surgeries, always keep the suction on. So don't make the blood trickle too much into the coina. Suction pressure, power increase, please. Keep it one side. Keep it one side. Give me one more suction. Another suction tip. It will come down, sir, soon. Because of the turn. No. Give the suction tip. Slow pannirunga, sir. Dexmet. Now it is sucking well.
So sometimes the nurse gives a blocked suction tip. Our training is the nurse should just take the suction tip near the ear and then give it to the surgeon, because she can hear the suction sound.
Yes.
And if she doesn't hear, she changes the tip and then gives.
Okay. Now it's
just
better.
a reflex they'll do.
Injection. Give the injection.
Especially in stapes microsurgery, the suction tips tend to get blocked very often, and you have to keep checking it by keeping it near the ear instead of putting it in water, which will take a few seconds.
So spin apparatum block on the other side.
Ahila, you use this greater palatine block for say you want to go into pterygomaxillary fossa. Do you give greater palatine block through the mouth?
Yes, I do a lot, but the thing is both the blocks are the same. Whenever I am not able to give the spinopalatin block because of extensive polyposis or gross septal deviation, I go for that block, transoral greater palatin block. So I have given good blanching.
Like silendoscopy, we learn from urology. The greater palatine block we should learn from dentists.
Exactly.
Because they do every day
Back
so many
first,
things.
first. You are getting the endo picture alone or SO picture also?
Both.
Both. Okay. So the infiltration, packing infiltration is done. Let's go for the surgery.
Another important thing you see, Ahilasamy sir is just taking all those blood-soaked packs and putting it in a container. The bad habit with some other surgeons are leaving it on the chest of the patient, and the blood will soak through the drape, and in the post-op, the attender will think we have operated on the chest and not the nose. So always keep these packs away.
Sir? Anything? It's okay. Saturation? Stop this. Am I
Ahilasamy?
She's snoring. What's her name? Duremal. Duremal? Little little deep. Duremal, Echulunguma.
Put a tongue depressor and stimulate the pharynx here.
Ma Echulunguma. Emma. Okay.
Satish is all right?
Patient is all right. She's a bit deep. I always like moderate. Tongue depressor irukuma koduma. Konjam stimulate panni vitta. As Dr. Anand said, we will little stimulate the pharynx. Durayammal, hardly any blood in the throat. Okay. Why mudikima? So, okay, meanwhile, please ask some questions. I'll be happy to answer.
How's the endoscopic view? Is the telescope okay?
I think I should compare with the stores. That's what I am asking.
I think we also use this Olympus only in our set also.
Okay, okay.
Otherwise, it's all the local make telescopes.
But your camera is a stores one.
Yeah, Spice.
Stores Spice. Section window. Okay, then fine, sir. Leave it. Don't worry. Okay, that's fine. So I need some working space on the left side. The congal crushing. Okay. I am going to do the congal crushing and lateralize the inferior turbinate. And sir, please tell me.
That's what I was about to tell. There is a septal deviation,
Yes.
and there's a concha.
Yes.
One, you got to correct the septum or concha without the crushing won't work, I thought.
Crushing won't work.
You do,
No, he's telling,
do a conchoplasty.
yeah, you have to address the middle turbinate, then proceed.
Yes. Let's try. If it doesn't work, I will go for a partial middle turbinectomy. This congal crusher is available with Sandoz Surgicals. Now you can appreciate the whole bulla. Sorry, my hand little slipped. You should not injure the mucosa. Sorry, you should not injure the mucosa. It's such a delicate, strong but non-abrasive instrument. Here little that's the main idea of this congal crusher. Okay, that's fine. Slight injury, sorry. That's fine. Always the main aim is when you don't traumatize the middle turbinate like this, your scope doesn't fall. Keep a pack. So no problem, I will keep the dressing forceps. Keep the pack for a minute or so, it will stop. Anthony sir. Just keep it for a minute. Meanwhile, give me the big elevator.
Yeah, tell me.
The space is enough?
The space wise it's enough, but inside that you are injuring the cilia on the lateral wall of the concha.
This
If you do a canchoplasty, both the side cilia will be working, right?
Okay, fine. Next step is I need some more working space. So, what? Keep the hand here. Anesthetic, sir, you are all right? Everything. So the patient little slept. So we reduce the dexamethasone infusion. Now saturation is all right. Pulse is all right. Everything is all right. So little reduce the or lateralize the inferior turbinate for a better working space. Now, I want the monopolar. Give me a pack. And the cartridge wire connect பண்ணுங்கம்மா.
Ahila,
Yes, sir. Yes, sir.
we are about one and odd time.
Okay.
How much time will you need?
How much time you should finish? I will finish.
Can you finish by 1:45 in another half an hour?
Now 1:10.
No, it's only 1:10.
Another 30 minutes I should be.
Yeah.
Definitely.
Yeah? Okay. Okay.
I'm actually, in fact, doing very slowly, being a workshop and everything. And the working space is very minimal. Cartridge wire connect பண்ணுமா?
One more thing I want to tell the audience, if you see the mucosa of this patient, it has a pavement-like epithelium.
Exactly, very edematous mucosa. Even after
It
repeated
looks like a stone pavement in an old town. The more pavement you get, the more rhinitis and the longer duration and the more difficult to treat such noses.
Yes.
This had pavement epithelium.
Okay. Next step is I will go for the mini FESS on the left side. See, still this patient is a very allergic patient. See, the secretions, everywhere secretions and edematous mucosa. Fine. Give me the backbiter. Set aada. Huh? Bar machine. You have monopolar. Can you have a monopolar cartridge? So now I will go for the MMA with Echulingima.
Selva?
Okay. So this is the uncinate ucharal, very edematous. No. She walked up. Couch section. Fentanyl 25. Don't give Dexmed, fentanyl. So what I have done with the backbiter, the window in the lower, I removed the lower one third of the uncinate and produced a window. That's called a Parsons window. And see, there is some fungal material is also there. Can you appreciate?
Yes, we can.
No problem. Give me the backbite or 45.
This will be called as a fungal ball, not
Yes.
allergic fungal rhinosinusitis.
Not AFRS, it is a
Not
fungal ball.
AFRS. Can somebody tell what is the IgE level CRP for these patients?
More than 1,000.
IgE was more than 1,000. These are two tests we do for all these patients. Total IgE and CRP, apart from CBC.
True cut, ma.
Ahila, you'll get your monopolar suction ready now.
Okay. So I am widening the MMA, the posterior part. Anand sir, can I get that? You have source scope? No.
Selva, I'm a regular scope கொடுத்துரு.
Okay.
Ahila, the visualization here is quite nice here.
Pardon
It is just the debris on the tip that's causing it, I think.
It is the
some material stuck on the front of the lens that's causing the
Lens,
poor
okay,
vision.
okay, I will clean it. Wait for a second. Tip. பெரிய கவுட் செக்ஷன்மா, வீக் கவுட் செக்ஷன். One of the disadvantages under local is you can't flush. You have to be meticulously, gently remove it. Block, clean, inner cover section perusu. So this fungus gets frequently blocks suction tip. Wait. I use a cautery in this area to make it less vascular. This case it is more vascular and everything. Let's try for the best. And backbiter Guma, make it a better MMA.
Ahila, they'll give you cautery. I am sure it's ready now.
Will it fit in that wire?
No. Your wire can't be used, but into your cautery we'll put a metal tip and you touch that with our monopolar.
Okay. So I need to do some more work on the posterior part of the MMA. Give me the true cut forceps, true biting forceps, and I will start elevating. Roller gauze small cut பண்ணி கொடுங்கம்மா. roller gauze small cut பண்ணி கொடுங்க. Small bit ma. I want half this size. Let's see. One of the reason this surgery doesn't popularize much is this area is a very vascular area, and many people when they go for searching the nerve, they cannot find out. But I am trying all efforts to make it a dry field to demonstrate you the nerve. Hope, let's pray we will do.
Ahila,
Yes, sir.
we have one more cautery machine called radio frequency.
Okay.
Into that your cable is fitting.
Okay.
So RF is a good machine. You just have to use coagulation cutting. 50% this, 50% that,
Okay.
and it will do very well this job.
Okay.
RF is nothing but a cautery which is very high frequency.
Okay.
It is made by this Ellman company.
Okay.
Ellman was a dentist, and so most of these radio frequencies are used by dentists, and they also use it for cardiac surgery for ablation of certain areas. RF is a very well-known technique.
Okay.
It will be more smoother than our monopolar cutting.
Okay, let's pray and do Thurapatum. Wait. Cautery, ready? I had to use this. Ready?
Selva, keep RF power 2 or 3, not very high.
3? Is 3 okay, sir?
Yeah, 3 should be fine. If it's not enough, we can increase it always.
Okay. I need the edges to be little.
Touch. Working?
Beautiful, sir.
Yeah.
So, for ideas, always idea Anand, sir.
Ayyo, this has been there for 20 years with me.
I always watch the social media. Every day you give some ideas, sir.
Yeah, that's what my wife also says.
So Aishwarya should be very lucky. And we all are very lucky to have you, sir. Small elevator.
Can you see this doesn't spark or give smoke?
I think this is enough.
It's a very smooth cutting cautery, that radio frequency. Very useful for sleep apnea surgery, tonsillectomy you can use. Instead of carburetor, you can think of this.
Always don't go above this level. Spina cresta ethmodalis comes at the area and the spinopelvic artery emerges there. Always elevate. So this is the problem. With so much blood, it is very difficult to see the thin nerve. Let's see. I will do some more coagulation. And the thing is, if you are not able to see the nerve, you just coagulate and come out. Elevator. See, this is the slender nerve. Can you appreciate the middle? That's not vessel, that is the nerve. I will show the vessel spinopelvic artery also notching above. See the nerve, see the slender fiber. And the fiber above also. Don't give anything. I will suction and I will put it. Give me a small pack.
Akhila, after cutting that nerve.
Yes. You always ask me the same question, will it regenerate or not?
No, I don't want that. See, I just want to ask you,
okay.
You now have a nice MMA. From there you can get a small, decent sized bone bit. You can use it to cover the nerve. It will prevent regeneration.
Okay.
Take a bit of bone from that margin of the MMA.
But usually we cauterize the nerve, that's all, sir.
Yeah, but you put a bone, after that, no regeneration, at least no reconnection. All our surgeries in nerve, we always think about promoting regeneration. But here, Ahilasamy doesn't want regeneration. We are all trained in facial nerve or hypoglossal or lingual, where you want to preserve.
Section crush panni pudinga. Okay, very good. Leave it gently. Give me the elevator. Section utruga. Full. No problem. Suction, when I ask you to catch, you please catch. I am doing multiple jobs. Take it out gently. Okay. See the nerve?
Yes, we can.
See the nerve? That's the nerve. This is the sphenopalatine artery nourishing above, the tending here, this is the nerve. So you finally got to see the tiger.
Very nice. If
So-
you want a titanium clip, we'll give you. You can clip the nerve also.
No, what I am going to do is, still some people in the audience are not convinced. So, give me the elevator.
No, it's quite clear. It's a nerve.
Clear, it's very clear. Some may say that it is artery. So, this said, what I am going to do is, I can bust it, but still I will cut it and so that it is not. Okay. This is always a surgery to be done under local prefecture or with a less bloody field. Elevator fast. By the time I come out and go, it pulls. So, okay, I will bus it.
Yeah, I think.
I will bus it. All the audience convinced or not? It's nerve or not?
Anybody thinking it is a artery or vein, please lift your hand. Nobody is convinced.
Nobody is convinced.
Nobody is convinced it's a no, it's not a vessel. It is a nerve they all feel. We all feel that way. It's fine. You
So
can-
this is a posterior
Yeah.
superior distal nerve. See, it is in the section. I'll just bus it. Oh, sorry. That's all. It's dead. Then you put the flap
Very
back.
nice. Very nice.
Thank you.
Very nice. Thank you.
Thank you. Thank you.
Does
And,
any of the audience can answer this question? Now,
and
facial, now we are very
I am
careful. We don't
Anand sir,
have
I
it.
am doing it for the 13 years, 12 years, and I have demonstrated this is the second time in a workshop neurectomy. Nobody else in the world demonstrated neurectomy in a live workshop. The second time after in Rhinacon Bhubaneswar I demonstrated, here I am doing. But this is one of the worst field, bloody field in which I demonstrated. But all thanks to Anand sir.
That's because, Ahila, this is an indicated case.
Yes, yes.
We are not giving a
God is behind us.
ordinary nose. No, this is a
Not to
definitely failed
disappoint
nose.
the people who was gathered. So in this side, I have showed three things: a conchal crushing, a mini FESS MMA simply done for a fungal sinusitis. I know the fungus is there enough. That's all. Maybe at the end, if you want, I will put the 70-degree scope and show. So this side, I will do the other technique. Less noise inside, please. Straight section. Bro, less noise. You can put slowly. So, Anand sir,
Yeah, Ahila, I'm here.
so I had showed 3 steps. Already this side again I am going to show. So now the time is 1:30 nearing.
No,
If you have
please don't.
something, you can
hang
go
on.
ahead.
Don't worry about the time. I know you'll finish it in 15 minutes. You do it, sir. We are with you.
Okay. Section block. Anasari sir, எச்சு ஒழுங்குமா
பெரியம்மாள் எச்சு முழுங்க
இதை ஸ்லோவாக வைங்களா நிறைய கொடுக்க வேண்டாம் ஃபெண்ட் ஜஸ்ட் கிவ் லிட்டில் she was snoring and everything. We stopped sedation. She little come out. Okay, fine. Emma, the thing is, you should not clean, doctor, clean. You should not over sedate also. Then they will not cooperate. Less. It's same thing like Anand sir.
Yes, Ahila.
You told tequila.
Take it.
Tequila should be also in the limited volume, less no effective, more they will not know what's happening.
So the technique you're going to do now is direct approach to sphenopalatine area.
Without doing any MMA.
Do you want a incision instrument with monopolar?
This is the incision area. I have Dr. Ahilasamy diathermy knife. Sir, not joking. I use for that endoscopy ear surgery, monopolar, my own innovation patented product, diathermy round knife, which I will use it, sir. Okay, sir? You can use anything right from Colorado needle, or even if I don't have anything, I use the same suction cartridge itself, I will use it. Same suction cartridge itself, I use it, but I will use my knife. You put a suction here. Yeah, no. Give me then my diathermy knife, my innovation, yes. These instruments are available with Sando Surgicals, Conchal Crusher, this one, then this uncinate dissector. These are all my own innovations. Ahilasamy uncinate dissector, which is a very good instrument. My videos are in YouTube. Poha pudinga, doctor. Don't give. See. So this is a prominent bulla. This is an middle turbinate posterior end. Don't go above this level. Always work this area. Don't give anything, sir. See, so sedated.
There is an announcement for all the participants.
Go ahead, sir.
Ahila, you proceed. There's a small announcement to be done.
Okay, you go ahead.
Afternoon post-lunch, we have a live surgery for left ear stepidotomy and thyroplasty surgery. In between both the surgery, there will be tea break. During that time, we are planning for a group photograph. I request everyone to present during that time.
I believe a group photograph is a very, very good memory. Even in the 80s and 90s, where we have gone for workshops, I've gone to many workshops, but only that Portman used to do this group photo. So you go to all these people who had attended Portman's workshop, you see that photograph, a nice black and white, and they will use the same tree, same place. So from him I learned that a group photo is a must. So we have arranged it outside. All of us will be there, and it will be a cherished memory for all. So please join us after lunch, stay peace, tea break, and photograph. Then we'll proceed with thyroplasty. Ahila, we are with you.
Yes, I got it. It is sticking to the mucosa. Hello.
Yes,
You can see that emerging from the foramen.
Yes.
Are you appreciating?
Yes, sir. Very clear.
Give the suction got. So I am almost through, sir. In another 2 minutes, you can start the other program, whatever you want. No, this one.
Other program, you also have to come. It is lunch.
Okay, sir. Last time when I finished my surgery on the last day, you were serving me Vangoli biryani. That's the first time I was having a Vangoli biryani in a conference. You remember, sir? I was late for the flight. I told
There was
keep
a time not much animal rights activists and all. We used to get this Vangoli around. Now it's not so easy.
Putting, catch. Block. Anthony, sir. He has gone out.
He's here. He's just
See?
coming to the mic.
This is a nerve coming out of the foramen.
You are not Janakiram.
See?
It's here.
See the nerve go above.
Ahilasamy,
And wait. This is the cresta epidermoralis and the artery arching, spinobattery arching. Ando, tell me, Ando, sir, small elevator.
Ahilasamy, you are not Janakiram. Only he can check whether I am sleeping or inside the hall or not. You can't do that. I am here only watching you. Lovely.
See, okay, it's very bloody today, but still I could show it. I will cut the nerve this side also. The patient's that trachea has gone little more. Catch. Leave it. Don't give it. That's the artery, see? That's the sphenoparotid artery.
Yes, we can see that artery.
This is a nerve. See? I can cut, I can coagulate. Gone. Well coagulated. So bilateral, we have got the tiger. Successful. ஏம்மா என்னம்மா செய்யுது? வலிக்குதா இல்லையா? நீங்க தூங்குங்க. முடிஞ்சு போச்சு. Okay. So the surgery is done. And I am putting back the flap. Usually I don't pack the nasal cavity. Anand sir, do you want me to pack or no? I don't usually pack for any nasal or sinus procedures.
No, we are getting it.
So from 2010 or 11 onwards, I have stopped packing the nose post-operatively. These clots with slight bleeding, oozing will stop on by forming a clot. And I don't get any post-op bleeds and everything. So I don't pack. If you want to pack, I think Dr. Ahilasamy.
No, none of these patients we also pack, Aguilar. There is no need to pack.
Okay. That's fine. Absolutely
Only
fine.
one step before we leave the patient, we'll put a 12 FG catheter into the nasopharynx, suction it, and put cold saline into the operated area. And that causes vessel spasm. And also...
That's for GA, not for local.
No, if you put a 12 FG, you can put even under local.
Okay.
You can, but you have to be careful and don't irrigate more than what the suction can withdraw.
Okay, so I am done with that. I will hand over